Maybe we can start off with some introductions. I'm a family doctor in Surrey. I grew up in Surrey. I was born at the hospital where I'm now the head of family practice in North Surrey. And I run a longitudinal family practice in Whalley for the past 10, 11 years. But now I'm moving to Newton, across from the wave pool. Those of you who know
Oh, really?
area, yeah, the wave pool, the Newton Exchange, where all the buses are. So pretty
Nice.
bustling place. Yeah, pretty nice thing. And I work with my family, which is kind of neat. We have a family practice. My two brothers, my wife.
Oh, really?
Yeah, and my dad is
Wow.
semi-retired. All family docs. It's in our blood. And
I love that. Family practice.
Family squared practice. And yeah, so we're really interested in doing high quality care. And we know that there are a lot of infrastructure things missing, and our current reimbursement structure and our lack of integration with the various silos of care really holds us back. And so that's one of the motivations for these types of online conversations. I understand that you can't really shift things until people have a vision of what can be done. And working with Jennifer's team at the Physician Quality Improvement Program, I've really gotten to know different methodologies and different tactics and strategies for innovation with teams that I think are really critical to primary care being a lot better in the future. And when I say better, I mean like patient experience better. That's really where I'm focused, because I feel really fortunate where I am and blessed, and I want to pass on those blessings to the community. So that's me. Can we go to you, Sabrina? Give us a little introduction.
Sure. So I am a nurse by clinical background and also a professor at University of British Columbia, appointed in the School of Nursing, but also at the Center for Health Services and Policy Research. And my work is really focused on delivery and organization of primary care. And so I'm all about primary care and how can we make it better, and how can we help patients get into I'm interested in, how do we make primary care a strong foundation of the healthcare system? And then how do we help patients access that strong foundation of the system? And also very interested in the social determinants of health and how that could be incorporated into primary care. So yeah, that's me in a nutshell.
You know what I really love? I mean, after meeting you at the, I think it was the Canadian Health, what does CHISPR stand for again?
Oh, the Center for Health Services and Policy Research.
The Center for Health Services and Policy Research, yes. So I met you at one of the annual conferences maybe 2 years ago. And I got the sense that you really can see the system's perspective. Like, you understand how all the big chunks of things ought to work together ideally. And you're in that camp where you're like, we can really do this better. There's so much opportunity. And I was like, yes, Sabrina. So, but I think Jennifer was really the catalyst for this conversation. I've been working with her for about, I think 4 years now, right, Jennifer, in quality improvement. And you had told me that you are interested in learning more about health policy. And I was like, I don't know much about that either. So tell us a little bit about yourself, so the viewers and listeners can know, and what your interests are in.
Sure. Thanks, Lawrence, and thanks for having us here. So my name is Jennifer Atchison. I'm a coordinator with the Physician Quality Improvement team out of Fraser Health. I got the role just a year out of graduating from my undergrad. So I went to SFU and did health sciences. I minored in gerontology, actually. And my health science degree was the Bachelor of Arts. So it was actually all about the social determinants of health. Well, mostly. And I think that's where a lot of my passion lies as well. So I'm doing my master's now in health administration, and I love it. But I've realized early on, and I think even before I got into my master's program in Regina, that I love health policy. I absolutely love it. And I love the courses that I took in my undergrad as well. So I'm really excited to kind of explore that realm, and hopefully my career will eventually take me in that direction. And it's about effective health policy, right? It's not just making policy that you think is going to work without any real basis in that decision. So I want to be part of developing effective change in the healthcare system, especially for marginalized populations. I'm really interested in Indigenous health and well-being. So yeah, we'll see where it takes me, I guess.
Thanks, Jennifer. And just for the listeners, some people listen with headphones on it, and I think it's your phone that has the vibration notifications on and near the microphone.
Oh, am I? Sorry.
I'm not sure.
Turn that off.
Oh, wait, this is your phone. You're actually on your phone. Yeah.
Yeah, because my computer wasn't working. We're having a day.
Oh.
Our technology is great today.
No worries.
Okay, I think that should work now.
Your phone is buzzing a lot.
She is a very popular person. I think that's what happens on a Friday. Thank you for spending your Friday night with us, guys. Wow, yep. we are the nerdy of the nerdy.
Except for Jennifer, her phone's going off like tomorrow.
This is true.
They're just wanting to text my dog. You can see her. She's the social butterfly in this situation, not me.
That is Peyton. Peyton.
Yes, that is Peyton. She's snoozing. You can see her paw.
No kidding. He's like done.
Yeah, she's kaput.
So, yeah. Yes, you had mentioned your interest, Jennifer, in Indigenous health, and we had talked earlier this year, you and I, about the Sanya's. I think it's called cultural safety training. I never followed through as I often.
Oh, really?
And I never got to do it. Did you start that training?
Yeah, I did it, and it was amazing. It was life-changing in a lot of ways. So I took an Indigenous health policy course in my first semester of my master's, and I really, really enjoyed it, and I learned a lot. But this Sanyas course gave me a whole new look at Indigenous health in Canada, and especially in BC, because Sanyas is developed in BC. I'm not sure, Sabrina, have you heard of the program?
No, I haven't.
Yeah, it's amazing. So it's all about Indigenous cultural safety, and it teaches a lot about the sort of historic trauma that has been put on Indigenous people in Canada, and especially BC. So it talks about, the hospitals, the Indian hospitals, and the residential schools, and the 60s scoop and everything. And it really goes through a detailed path as to how we got here. So it's very interesting. So that paired with the health policy course that I was taking for Indigenous health was very eye-opening, because that was looking at a lot of different case studies of things that had happened in the healthcare system when Indigenous people were trying to access it. And now recently, with Adrian Dix announcing that they're going to be doing an investigation in how some Indigenous patients have been treated in emergency rooms in BC. I'm really curious to see how it moves forward, hopefully forward anyways.
There was that really ugly issue of some unfortunate staff at a hospital who were supposedly playing a type of guessing game about the blood alcohol level of a racialized group of Indigenous peoples potentially. And yeah, it's a really unfortunate, but I'm glad that the powers that be are trying to look into it. And
yeah, me too. I do kind of have doubts that this is the first time that that's happened, though, because I think it's a very systemic thing, as we've talked about a lot in the past couple of weeks. I think maybe what's going on in the States is bringing attention to it more, and people are noticing when things are going awry a little bit more. Yeah. But I think that sort of treatment this is not an isolated incident. I think this is probably just the first time it's been recognized on the public stage in BC.
And if people wanted to try to take that Sanyas training, how do they find it again? I know for us in the Health Authority, it's in the Learning Hub, the PHSA for Provincial Health Services.
I'm not sure. I think you can probably just Google Sanyas and it shows you everything on there.
Which is apparently SANYAS?
ANYAS, correct.
Okay.
Yeah, so it's an amazing course. They pair a lot. So you're doing journal entries and discussion with other members of your class in that cohort, and you're also watching documentaries, which are super, super interesting. I think that's my favorite part about it all. But yeah, so you should just be able to Google Sanyas and find it, and it should be available for free to anyone who works in a health authority in BC.
Mm-hmm.
And I personally think that it should be written on our policy that it's a mandatory course for everybody. But
I like that. Mm-hmm.
That's a whole other rabbit hole.
Have you guys heard of Equip and the modules that they've developed?
I have no idea what it's about, but I have heard of it.
Well, I don't know. I sent you guys a link for our last podcast, and it was kind of funny. We brought up the Equip Health clinic, and we actually brought up their website. What a coincidence! That's a good plug for the last episode. So, But tell us what you like about that, Sabrina. Tell us more about Equip.
Okay, so I will declare my, I guess, conflict of interest up front that I helped them to create it, mostly more on the sort of tester user side. And I've been involved in the research that helped to develop the Equip modules, but it's really the staff that put it together. So I just thought it was a wonderful tool for primary care staff in particular, but really anybody to take it. And there's these different modules that go through, what are the different constructs in terms of equity-oriented healthcare. So it really kind of goes through, trauma-informed care, culturally tailored care, and what's the other one? So trauma and violence-informed care. There's a whole bunch in there as you're talking about that. So I think, again, it's not just looking at words on a page, but there are, as you said, Jennifer, there's some videos that are really good to be watching, and then there's some reflective questions, and the reflective practice, I think, is really, really important about how we can think about in practice to basically go about equity-informed care.
That is so cool. I had no idea you had made it. What a coincidence. I knew there was a reason. I knew there was a reason why I was attracted to have you on this call. That's amazing. So Equip Healthcare, I think it was equiphealthcare.ca.
That's awesome.
Equiphealthcare.ca,
and there's a wonderful toolkit. And
it's free modules as well for healthcare providers, and really wanting it provides like practical ways in which you can start to work better with patients. And it's not just those who are marginalized, but just anybody, because I think you can't just have one practice for some people and then another practice for other people. But really what you're trying to do is have people who are performing equity-oriented healthcare for everybody. That's going to be, where you're going to get the most bang for your, as a provider, I guess.
Yeah. That's amazing. I'm excited to look at that tool box there. That's awesome.
Yeah. And shout out to Drs. Colleen Barco and Annette Brown and other folks on the team that really have worked hard to get that up and going. I just was a little small part of that. And really, we learn from the patients, right? In the working with the patients, alongside the patients, and them telling us what's important in terms of primary care to them, and how they want to be treated, and what's important in terms of care. And it's not simply just, okay, look at, you're coming in, you need a pap test today, or, let's get you a blood test. Like, that is not kind of, where they're wanting to start. So, yeah.
I know it was probably a big team that created that Equip Healthcare thing. And like you said, there was Colleen and Annette. Tell us about them. And you don't have to get into specifics, but like, what drew them to have the passion to create a tool like equiphealthcare.ca?
Yeah, so I mean, they've been working for years in terms of equity oriented care, and in particular, um, working with Indigenous populations and trying to draw attention to the health disparities and health inequities, um, but also to create the theories that really would inform the toolkit. So they started with developing the theories, as you were saying, Jennifer, really trying to understand decolonizing approaches. And then we started to move it more into a practical realm of, okay, well, how can you enact things like cultural safety? How can you provide trauma and violence informed care? What does that actually look like, right? Because those are the questions that we get from providers all the time. Well, what can I do? I work in a sort of a fee for service system. I have to see patients in this way. So, how do you kind of counteract um, neoliberalism in healthcare, right? Which is the neoliberalism is really around sort of a fee for service efficiency model. It's a throughput model. And it's all about really basically relying on the individual to come to you for healthcare, to a clinic, and to, listen to the treatments and then basically individually move forward. And we don't understand why that doesn't happen. Like, there's just so many reasons. So, yeah, I think they have a long history of doing this, and so this is now some of the work.
So Jennifer, I mean, does when you think about health policy, what are some questions that come to mind for you?
Um, well, as Sabrina was talking about fee for service, that's a huge part of it for me. I'm constantly struggling in my brain in terms of what's the best option, fee for service or salary or any other options that are available. And then I think as well, like private versus public. Our healthcare system is so founded on the idea of public healthcare and delivery, but over the years, we are definitely moving towards more privatization of healthcare, and so I think those two topics are always in my brain because it's just such a foundational thing. If we don't have that, really secure and figured out, it can change how care is delivered to so many people. So yeah, that's kind of the questions that always are coming up. Are like, what is the best option here, and are we doing our best with what we have?
And Sabrina, you probably have, the lay of the land in terms of health policy in BC better than most people. So what is happening in those areas, that negotiation between private and public and services, and how we have been going and going forward? What is the Mhm.
I mean, that's sort of the lay of the land is we've always depended on private services and privatization. So if you think about the long-term care sector, for instance, and all the stuff
Yeah.
that happened there, that's mostly privatized. And then there's also a lot of, if you think about primary care, it's a publicly insured system, meaning that we have one insurer, but it's really privately delivered. And clinicians can bill, in fact, doctors can bill fee for service. So nurse practitioners can't bill the system, but that the fee for service system is specifically set up for privatized billing, right? So essentially, in some ways, it's publicly funded but privately delivered, and that is a big source of tension that we come up against because, as we know, fee for service would influence different behaviors, right? So if you provide incentives for something, it will have an effect on behaviors and yeah, so that's kind of, and hospitals are paid through a different system and through with the health authorities, and health authorities need to have they have to have a balanced budget by the end. It's not like they could save money and then just carry that over and have a surplus for the next year. So they need to get rid of their, they have to spend the money that they have, and then they have to ask for new money every year. They get a global budget, and they have specific monies to run their hospitals and community-based services. And the health authorities then need to interact with the privately owned and operated primary care fee-for-service clinics, right? Or and I guess another example are the walk-in clinics, which are also privately owned and operated, but publicly funded in the sense that they can bill the fee-for-service system for services provided. So
yeah, essentially what we've set up is the ability for fee-for-service clinicians to not necessarily operate in the best interest of the community and potentially operate in the best interest of the bottom dollar within their clinics. Mm-hmm. And there is nothing holding them accountable to population health outcomes, nor patient experience outcomes. And that is a big challenge. And I think if you go on ratemds.com, you're going to see a lot of the patient experience challenges. And if you review the Blue Book for MSP billing, which is publicly available, there is a significant mismatch between kind of maybe what's needed in that community and where the publicly funded dollars are going. Mm-hmm. And so we have everybody working in different silos with different priorities and potentially their own different mandates, but it's all publicly funded. And then how do you manage that? Mm-hmm.
That's challenging.
It is.
So, I mean, they're trying to move towards, primary care networks. So the Ministry of Health is trying to move, and I think that's an attempt to really try to create a governance structure whereby divisions of family practice, which are agglomerations of private family practice, to work with the health authority to then provide care to a particular population. So, that is sort of rolling out, and to try to take advantage of the resources within areas. And I think, to be fair, there is what we call alternative practice payments, which are like salaried kind of positions, more so that happen sort of in the northern areas of British Columbia. And so the drivers for working together and collaborating are different. One, because it's rural communities, so there's much more of a sense of we have to work together. And then also because you take away the sort of the pressure of fee-for-service. And I do think it's a real pressure for physicians. They didn't go to school to be business people. They went to school to deliver care. They learned how to do that. That's what they're an expert in. And so I've been doing a survey of primary care clinicians across the country, and for the last, 10 weeks. And the pressures that the family physicians feel is enormous in terms of fee-for-service. And, during COVID, the patient volume dropped. And so then they wondered how they were going to stay open, how they were going to pay for staff. So the business side of primary care provides a lot of pressure. And it then, of course, people are very worried about that as well. So, if you take that away by doing sort of more salaried, and I don't know what the right model is, Jennifer, because I don't think it's probably all salary and it's probably not all fee for service, but there's probably some kind of hybrid in between that's going to get you sort of the best, productivity of the family physician, because they have some incentive to work harder because they get more money. But then also provide ability to work with others and feel like, okay, I do have some time to be able to dedicate to the patients that I need to do the work.
Mm. There's, what came to mind when you were speaking about some of the health authority budgeting issues of how, you have a set budget and then you have to kind of chase that budget and then spend. If you don't spend the extra money you have, you're not going to get it next year. And then we might be in trouble next year. So let's spend even if there is not a current need right now. And that is so frustrating. I think it's frustrating for almost anybody in there, but it's like, do I want to put my colleagues at risk of not having budget for their income next year? So to self-preserve, let us spend that money. And it just feels so crazy. It just feels so crazy in that situation. But yeah. So yeah, we have a interesting system that needs a lot of change. And is health policy the way to that change?
Yeah. So I think health policy can help because the policy world will have specific levers that you can then try to drive the system, right? So health policy, an example of a system lever is, okay, we're going to create primary care networks. So they create the structures and they fund primary care networks and they ask people to behave in certain ways, have certain accountabilities. So that's how the policy world can help. And then it's going to come down to organizations and individuals within those organizations to really say, okay, let's operationalize the policies, right? So an example of a primary care network that we're working with right now is Kootenay Boundary. And they have a PCN that's moving along. And they're starting to really kind of start to work together. So they have a social worker that works within the primary care network. They've got 4 different nurses that are working across the different family physicians' offices. So, it creates a different kind of model. And the policy folks can help to try to provide a broad-based vision of what this could look like in the future, as well as they have funding levers. So, yeah.
When I hear policy, like for me, it sounds like you write something on a piece of paper and then you disseminate it and the people read it and they're like, okay, we have to try to follow this now because a bunch of people who are intelligent and did some research put it on a piece of paper. Is that what policy is?
I wish I could say that. That'd be awesome. If everybody listened to me, it'd be awesome. No, they don't. So policy, I think policy is a combination of different things. So one is what's going on in the environment at the moment. And then another one is so that it's about the timing. So there's this thing called Kingdon's windows. There's 3 different streams that come together. I'm gonna not remember the stream. So there's the sort of there's the timing of what it is that you're trying to move forward. Then there's kind of the opportunities. So are the policy makers interested in that? And then there's kind of the context of what's going on. So right now, trying to address systemic racism and discrimination is something that it's a timing issue, right? So you can see Adrian Dix is going to do an inquiry into systemic racism. And Jennifer said it perfectly clearly earlier that this isn't the first time this has happened. It just that these windows are coming together. Right. So it's the problem, the policy, and then the politics. So the politics are that this happened. We saw George Floyd. We saw massive demonstrations here and in Canada. Then the problem is the systemic racism and discrimination And all of a sudden, we have a window because now we're going to have an inquiry and potentially could see some recommendations in terms of policy, in terms of, okay, well, let's just, this is like, pie in the sky, but everyone has to do training on trauma and violence informed care. And that could then become a policy. So this model is good in terms of looking at things that have passed in terms of policy, but it doesn't help you with what might happen in the future because it's hard to predict what's going to happen. But it's a helpful framework to look at, just to think about, okay, what's the timing on all these things, and are they going to come together? Yeah.
I mean, that makes a lot of sense. You wait for a moment in topical happenings and to see, oh, this is a great time. We have a policy ready. Let's try to get everybody to look into and see the value of the Sanyas training potentially, like something like that. That's interesting. I mean, that makes a lot of sense. Kingdom's three.
I love that. Policy. I've never seen it before. Never. They don't teach you that stuff in school.
No, I learned that in my, I went to a policy program. I took a policy course out at UC Berkeley when I was down there doing my degree. And I thought, oh, that's probably outdated. They're probably using different methods now, but it's sort of a nice framework to kind of be able to use. And like, for instance, when you look at what happened in terms of fee-for-service and how did that all come about and why are other countries doing it, it's because there was a guy at Stanford and he was like, well, you'll have to have competition. So if you have competition within the system, then you're going to get the best ways to move forward in terms of providers, competing against each other to provide the care. And so all of a sudden, there is fee for service in other countries because this person at Stanford was saying that, I can't remember the person's name. He's a famous guy around, fee for service. So it's interesting. Like I was talking with China at one point, and they were very interested in the shortage of primary care workforce, and they were interested in bolstering their workforce. So many different universities across Canada started to work with China, and in the U.S. as well. And I mean, it's like a huge country, and so some of the talks that I was involved in was around how do we get family practice training programs, and China came from a background of having what they called the barefoot doctors, which essentially the barefoot doctors were kind of like advanced practice nurses, but they were called advanced practice nurses. And so it was an interesting thing because they really liked the idea of having a doctor because that's very prestigious. And they just really repelled the idea of having nurse practitioners and training nurse practitioners. So, I mean, that's another kind of where you can see, okay, well, some of this is around politics, and then some of it is around policy, but policy is really gets influenced by different things. A little bit by evidence that's out there, a lot by politics, and also around sort of what's the public pressure that's happening at the time, right?
So let's go to an imaginary world where we have a mouthpiece. We have a political mouthpiece that could shout from the rooftops and be heard of what needs to happen in policy. What would that mouthpiece say?
Jennifer, what do you think?
Oh gosh. I don't think I know enough yet to even say.
You do. Don't discount your experience as a patient in the system, as we all are. So what are some ideals? And I'll say mine after you go.
Yeah, well, I think that early access to equitable care is what everybody needs, despite wherever they come from, right? I think everyone needs to be mindful of each other's experiences, and that comes in with the intergenerational trauma of the Indigenous people. It comes from the experiences of refugees. It comes from people who have lived here for a long time, but they're technically white settlers, and maybe they're dealing with other things such as poverty, or maybe they're a marginalized group for some other reason. I think that no matter who you are, privileged as well, everyone should be able to access the care that they need. We need to meet them where they are. And I think sometimes that's kind of overseen a little bit.
I would totally agree. I think that we have quite a few resources and services and talent available, but we don't have them ready to meet those who potentially most need it, as you said, the marginalized communities. And I think policy could reshape that. And policy, using a trauma and violence informed lens and understanding the social determinants of health, we ought to have, move some resources upstream to school-age children, to parenting training, potentially, because of the consequences that we know with the compounded interest of unresolved trauma and challenges like that. Like, it's there are so many opportunities upstream, and we started this conversation. I don't remember if it was recorded, but primary care is not always sexy. It's more sexy to talk about, where the blood is. That's where you can see the blood, the surgery, the emergency rooms, and the intubations. But could we have reduced some of those? Could we save $1 billion by doing upstream care? And I think we can. I really think we can. And I think we do need policy, and we need politicians, and we need voices like ours and conversations like this to try to get there. One of the interesting conversations I've had with Marika Sandrelli, who's one of the Fraser Health trauma and violence informed care or trauma responsive care trainers in Fraser Health. I'm so excited that we actually have a trainer for trauma and violence informed care. But she was saying that often people with significant trauma histories, they get really sometimes turned off by their initial interactions with healthcare, because it can be triggering. It can trigger them and trigger a fight or flight response and a flight response often, and that results in them disengaging from care. And that disengaging from care reduces their ability to access any coaching or any ideas or resources that could actually get them more well. And then so our lack of use of a trauma and violence informed and trauma responsive methodology or training is costing us millions and potentially billions of dollars because of disengaging from care early on in disease processes. And it's tragic. And I think some people are really aware of that, but for some reason it hasn't gotten to where it needs to go in terms of the politics of it. And it's almost like people are like, suck it up. You got trauma? Too bad. Adapt to our system. It's your job to come, as Sabrina was saying earlier, your job to come and communicate perfectly, exactly, and figure out what the doctor can offer you and package yourself so that the doctor can meet those needs. And it's a kind of backward system. I should step off the soapbox now.
No, I think that's good. And I think I was going to say, what was I going to say now? Of course, I've forgotten.
You got to take notes, Sabrina, when you're talking on these things.
I know. I need to be much more of a nerd to get my stuff going. But
Peyton.
Oh,
Peyton's like, who's talking?
Where am I?
I'm like, oh.
She was dreaming.
I think so.
Oh, I love those dogs. They're my favorite.
They're awesome.
Yeah. Okay, I can't remember. It'll come back to me. Don't worry.
It'll come back.
Yeah, it'll come back.
I wanted to show something that I saw at one of the Centers for Health Services and Policy Research Conferences. Is that what CHISPR stands for?
Mm-hmm.
Yes, I got it. I saw this model, and I think your team had brought somebody up from Washington. This is called, the author of this model is Bodenheimer.
Yeah, Tom Bodenheimer.
Okay. Was he the one who came up to speak?
No, it was my colleague, Kevin Grumbach.
Yes.
Wow.
I remember he had like a mustache and looked really nice. But anyways, high performing primary care, and the foundational building blocks were engaged leadership, data driven improvement, empanelment, which I think it means like really knowing who your patients are and figuring out kind of and having longitudinal relationships with them probably, and team-based care, so making sure that you actually have a pretty good functioning team there. Did I get that kind of right, Sabrina?
Yeah, no, that's right. That's right.
Yeah.
That's absolutely right. Yeah.
And then kind of the next steps, advancement and evolution, you have to have true patient-team partnership. So the patient really is able to communicate their needs exactly with a team that's responsive. Number 6, population management. And I think that is connected to data-driven improvement, where the clinic team is actually looking at metrics of maybe how diabetes is controlled, maybe at the effectiveness of mental health management using validated scales, and then figuring out if they need to shift the resources or be more proactive in their care. And number 7, continuity of care, again, longitudinal relationships, and making sure that we're following patients through the system from acute care to tertiary care and primary care. Did I get those kind of right? I guess so.
Yeah.
And then 8, prompt access, exactly what Jennifer was saying earlier, and comprehensiveness and care coordination. I'm guessing that means kind of like outside of your primary care home. You can kind of reach out to community services, etc. And number 10, I'm not really sure, but I think it just means that we know that there's a wonderful paradise once we've gotten all these, a template of the future integration. I guess it means like all of a sudden EMRs are communicating with each other. What do you think of that, Jennifer, when you look at it?
I think it's great. I think they encompass a lot, and probably each single step there we can unpack so much. I'm most curious about empanelment, because that's a term I don't think I've ever heard, and it's interesting to know sort of what that looks like, because out of those 4 foundational blocks, I feel like that's the one that might be lacking the most in our system, perhaps. I mean, you could argue probably for all of them, but I think in general, like with the nature of a lot of primary care, where people are going to clinics, they don't have family doctors, things like that. I feel like that probably is lacking for a lot of patients. So that's kind of my thought, is that I think those 4 foundational things are foundational. But without that consistently across the board, I don't know how we can get to the other parts.
Yeah, I would totally agree with that. And, speaking from my own lived experience as a family doctor, 1, 2, 3, and 4 are not existent. I don't know any place that has them all existent. Do you, Sabrina? And how can I sign up?
No. That's your utopian right there, hey?
Yeah.
Yeah.
What sticks out to you from this model, Sabrina? Is this something that's pretty commonly looked at in your circles?
I don't think in British Columbia, we haven't really kind of taken this up. Like, they've more moved towards patient medical home and thinking about what those different pillars are, which they actually follow quite closely.
Yeah,
by the way,
they do. They do.
This. And I think so. The thing that really sticks out to me is, the thing that one of my passions is, one is around team-based care. The other one being patient partners. And then 3, the data-driven improvement. So, I mean, how can we actually be doing QI or research any kind of transformation in primary care without really knowing what's going on at a level beyond just individuals, but really sort of at a practice level and sort of within a division, a family practice, or a primary care network. Did you know that nobody knows how many patients in Vancouver Coastal have chronic obstructive pulmonary disease?
Yeah.
Right?
Yeah.
Wow.
Nobody knows. Nobody knows anything really. It's all extrapolated data. We're all doing guesswork because nobody's collecting it, and nobody has noticed that it's time to look at these things. And how many patients is it now who don't have a family doctor? I know Canada-wide, it's estimated to be 4 million plus.
Wow.
4 million Canadians without a primary care doctor.
Yeah, I mean, I think in some areas of Fraser Health, like I've talked to physicians and they're like, this is not a problem for us. Like if you talk to White Rock Division, they're like, we have like 97% of the people have a family physician.
Wow.
So this is not a problem for us. But then you talk to other places and it's more around the national average. So the national average is 85% of the Canadian population has a family physician that wants one, right? Because the other thing is people have to want someone. And that's what gets to empanelment. It's like the empanelment really is meaning around having a roster of people that you then are able to follow, that you're, quote, the most responsible team or the most responsible provider. So yeah, I mean, I what's really interesting is, like, for instance, going back to the chronic obstructive pulmonary disease example, we know those people who visit a secondary acute center for chronic obstructive pulmonary disease. We know people who go in for hospitalizations, and there's a billing that's generated, but we actually, that's what we know in terms of, like, we don't actually know. Like, could you tell me in your practice how many people have COPD that you need to follow and manage as a clinic in your patient? Like you must have like 7,000 to 10,000 patients.
Yeah, so we're lucky that the General Practitioner Services Committee, and this is very recent, within the past year, General Practitioner Services Committee under the Doctors of British Columbia, they have a group called the Practice Support Program, where they bring coaches in to primary care offices, and they work with you through the auspices of the division to kind of clean up your electronic medical record charts and to use the power of your electronic medical record to actually register every patient who has been either billed for chronic obstructive pulmonary disease, or even if you haven't billed it into your when you've sent invoices to the government for medical services plan billing, that you actually could have had an entry point in a discrete data way in the chart that they have that particular clinical entity. And then so you can now, and then you, with all that, if it's categorized and discretely entered into your EMR, then you can pull the data correctly. So I'm lucky that I'm one of those who have gone through that, and there was funding. I was funded, I think, through public money to clean up my EMR. Not a lot, but a little bit. Maybe like, a couple $100 to do that. And we did that. So we can, but I know not everybody did that cleanup stuff. So you're right.
Lauren,
yeah.
Did you find value out of getting that done?
Absolutely, because what that allows you to do now, from at least a local clinic population basis, now I know who I have to watch out for, because chronic obstructive pulmonary disease, it can be deadly. And so if I can stay on top of it, I can actually get my computer to give me a list. I get my staff to call them back and say, you know what, with chronic pulmonary obstructive pulmonary disease, we got to make sure we check your pulmonary function regularly, make sure you're up to date on your medications. I want to figure out what your risk factors are, those calculators that you can calculate their risk for actual exacerbations that would put them into the hospital. And every exacerbation adds up your risk for actually dying. So if we stay on top of it, we can actually reduce their suffering and reduce the costs on the system. It's a win-win if you have that data-driven capability. But not every physician has been awoken to the potentials of that ability with their EMR. Some are still like fighting the EMR. They're like, I don't like EMR. Give me back my paper charts. I want to continue to, and I don't blame them. Every change is hard. And thinking of even more things than just the lives of your patients individually is hard. Finding that capacity to step away and look at your practice from a perspective of, am I doing good business? Am I actually helping my population? Am I doing things that are evidence-based? Like, that takes a lot of capacity and mind ability to do that. And you need to have support. And if you've never taught business management, like Sabrina mentioned earlier, how are you supposed to have the countenance or the room, the cognitive room to do that? So,
yeah. So I have a perfect tool for you in terms of data-driven improvement, because that's great that the practice support program came in. But there's a way to continue to do that.
Okay.
Over time, right? Because you can't just keep getting the practice support people to come in. The idea is that they help you learn how to do it, then you're apparently doing it on a regular basis, right? Mm-hmm. So they provide some support, but of course, we know that our experience has shown us that once you sort of take away that support, that the charting or the ability to look at that stuff goes down, because, as you just said, you get busy, and it's like, listen, like, I got other things to worry about than trying to have perfect records, right? Like, so there's definitely there's the Canadian Primary Care Sentinel Surveillance Network that is sort of like, it extracts the data and then it can show you like what your patients are that have, for instance, COPD, and then you can sort of see who those people are all the time, and then have an updated list that you could then go back to your EMR and then sort of update it, rather than kind of doing a search and stuff like that. So there's definitely ways to help you do more.
I've heard of people call this CPCSSN, and there are no vowels in this, but they still call it CPCSSN. The Canadian Primary Care Sentinel Surveillance Network. So this is one of the databases. And where does CPCSSN get its data mostly from?
From primary care EMRs.
Oh, so primary care EMRs have kind of contracted to push their anonymized data to it, right?
No, clinicians sign up. So individual clinicians or clinics will sign up. And then once they've given their permission, then the data are extracted de-identified data are extracted. And then the clinic always, the physician who signs up always has the ability to re-identify the data at their practice for their purposes. So that's one of the things that we provide as a service. Is you can then, because once you can re-identify it at your practice, you can then perform the quality improvement. So we're trying to provide people with tools back for quality improvement.
That's cool. And this is a kind of like a nonprofit data governance thing. Or?
Yeah. I mean, at this point, it's a network of networks, and the central repository sits at Queen's University. But for instance, British Columbia has its network, and once we're happy with the data, it's cleaned, it's de-identified, all that kind of stuff, then a copy of the BC data would go into the central repository, and that happens in British Columbia, Alberta, Manitoba, 5 different places in Ontario, Nova Scotia, and Newfoundland.
You know what?
Sabrina?
Go ahead.
I was
Jennifer.
just going to say, how does it interface with the health authorities, if it does at all? I'm curious about that part.
Yeah, so we are working with Interior Health Authority. So we have a permission to work with the different owned and operated clinics within Interior Health. And then we basically work with their data IT people and pull the data from those particular clinics. Or we don't pull the data, they're actually, it's given to us from like the IT people on their end, they do it all. So we provide them with the coding, the codes, and then they pull it for us. And then they provide us a copy. And then we do all the transformation and cleaning and blah, 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 all that stuff. And then we'll provide it back to those clinics, same as we would with a fee-for-service practice. And we have this tool, it's called the data presentation tool, where you can play around with it yourself. So you have control over looking at your data. What is it that you're trying to discover? Blah, 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 all that stuff. Yeah. Does that answer your question, Jennifer?
Yeah, I can see that as a great way of engaging people to kind of work together.
Yeah. Yeah.
And currently in Jennifer's program, the Physician Quality Improvement Program, there are a lot of community-based physicians who are like family doctors who are signing up for the program. And it would be nice to share with them a database. One of the databases that I contribute to that I signed up, I'm going to sign up for CPCSSN too, but is the Health Data Coalition. And I'm sure you've heard of them too, right, Sabrina?
Yeah.
Yeah. So what are the differences that you can see? Because I don't really know much about CPCSSN enough. I don't know enough to say what's different.
Yeah, I mean, I have to say I can't really speak to what the Health Data Coalition is doing because they are doing stuff all the time, right? So I wouldn't be an expert on what it is that they're doing, but I can speak to what CPCSSN is doing. So we have invested the majority of our resources on making sure that data is valid and reliable data. So, I can show you all kinds of things just in terms of how unclean the data are when it's pulled out of the EMR. Everybody probably thinks, oh yeah, my data are pristine and it's really good. But when you pull it out, it's actually not that good. So for instance, billing data is excellent because of course you get paid by fee for service. So the billing data actually doesn't change that much in the transformation. But then other things like lab data or medications, prescriptions, or risk factors like body mass index or smoking status, those things change a lot. And it's because of the cleaning and transformation process that kind of goes on. Because many of the EMRs, they don't have necessarily like a drop-down menu in terms of smoking status. So we get things like no, never smoked, no, not smoking now, past smoker, right? And so when you see all these things, you have to figure out, okay, which category do they kind of fit in? Can we categorize it, et cetera? So then that's how you get to smoking status, because we believe that we're not going to work with sort of what we call front-end users or the clinicians to clean up their data because they're just simply too busy. It's not their priority, all of that kind of stuff. So we'll clean it up on the back end once it's extracted, and then we'll provide it back in this data presentation tool for things like quality improvement, et cetera. So, and, just so sort of, how you get like, there's maple syrup that's like cooking grade maple syrup. So it's a really dark stuff, right? Mm-hmm. And then you get sort of more like delicate maple syrup, like the A grade maple syrup that, is really good in terms of putting on pancakes, like eating raw, like you're not putting it in baking and stuff, or you might use it to infuse whiskey or something like that, right? So our research, our data are, I would say, I guess, A grade in that sense, research grade data. So it's ready to be used for one, linking to other databases. So you could, like, for instance, follow patients' journeys across, when they were hospitalized, what they were hospitalized for, then they came back to primary care. This is how many times they saw primary care, all that kind of stuff. So it's that's what we're able to provide in terms of the data. So
yeah, those algorithms that you guys use to clean up data, that would be really, really interesting. In the research world, or they always say garbage in, garbage out. But it's like you're taking garbage and you're purifying it.
Yeah, exactly.
making it useful, making it tasty and delicious.
What we try to do is we take data elements and we're trying to create knowledge from the data elements. And now we're moving into, okay, our data are good enough to now start to be using for creation of clinical decision support tools that would help exactly with what you just said, Lawrence, and that is decreasing cognitive load and integrating decision support right into the workflow to make your workflow easier. So, let's take an example. How many people do you have that come in on a weekly basis that need a antibiotic prescription?
They actually need it, very low. Who want it, pretty high. So need, I would say maybe like if I had a busy week, meaning like saw 100 patients that week, for me that's a busy week. Out of 100 patients, maybe two need it.
Yeah.
Mm-hmm.
Yeah. So so we're trying to make this antibiotic prescription module that would just be integrated right into the workflow. And so what you would be able to do with the patient is be able to say, excuse me, you would enter in whatever it is that they have, and then it would spit out for you a prescription. So it's either the right prescription, like let's just say nitrofurantoin for a UTI, or it's like a prescription for what you would do with a viral infection, and it follows like the choosing wisely stuff. So you're able to give something to the patient, but it's really not a prescription for antibiotics, right? Like it's more like, okay, take some Tylenol, get lots of fluids, that kind of thing. So that's the kind of like, so then it helps to decrease cognitive load for clinicians, and they can spend that cognitive load more on more complex issues.
Yeah, so you are interested in health policy, but you're also interested in workflows and data-driven improvement.
Yeah.
So there's a lot there. Amazing. How did you find yourself in this area, Sabrina? How did you end up being the queen of this thing, this health policy?
Which one, the data?
Or
all of it?
All of it.
Yeah, I think Jennifer, you hit the nail on the head. You just said, this is something that I'm really passionate about, and this is a place where I want to make a difference. So, I mean, I'm willing to basically pour my life and heart and blood into what I can do to help out. And so I think that's, I've been fascinated with, can you use electronic medical record data as an information source around primary care, and developing a way in which you can actually see what's going on in primary care? Because when I first started in this area, it's like, yeah, nobody appreciates what I do. It's really a black box, but yet it's supposed to be a strong foundation. Barbara Starfield said it's, a foundation for the rest of the healthcare system. So it's really important, but we don't really even know anything about it. So then I saw this opportunity with Citizen, and I thought, we got to get this in BC. We have to do this.
So you are the operationalizer in BC, I guess, when it comes to policy, because that's the most challenging aspect of it all, it seems.
Well, so in terms of Citizen, yeah. Yeah, in terms of health policy, there's lots of kind of other people that are also influencing, but I really try to cross both the clinical world along with the research world. And then to try to bring those perspectives along with patients' perspectives, to decision makers. So, because it's really interesting that everybody basically is so busy. They're working in their different areas that it's hard you have to really work hard to move into a space where you're kind of working in between the three: patients, clinicians, and decision makers. And so I think researchers can play that role, in being in the university. And so it's a little easier for me because I don't have patients that are waiting for me in a waiting room. And I'm also not a patient who's sick, who has to go to all their appointments and stuff. So,
Right. Well, then I guess the fact that you have your clinical experience really, really helps you because you understand that side of things. You understand what's needed from the clinician's point of view. That's good.
Making an appearance. And Jennifer helps a lot in the physician quality improvement program to bring patient partners into quality improvement. Tell us a little bit about what you do there, Jennifer.
Yeah, sure. So as part of the physician quality improvement program in Fraser Health, I guess I've sort of adopted over the years that I've been there the role of the patient partner liaison for our team, because from the beginning, the man who really started the courses and the teaching and everything like that, Dr. Kurt Smetcher, he said from the beginning that the patient is so, so important to everything. Sorry, she's snoring and it's really distracting.
Oh, we can't hear it. It's probably right in your ear, but we can't hear it. So fine. Oh, baby, it's okay.
Anyways, he started right from the beginning saying that patient partner involvement is crucial and we need to have them at the table. So in cohort 1, we're in cohort 6 now of our program. But in cohort 1, we had a patient partner fully involved in the project or in the cohort itself. And from the start, we have always had a patient partner involved in our training. And as my role has developed, I've tried really hard to bring patient partners in other levels. So at the individual project level, and then at the steering committee as well, which has always been a thing as well. But now we're on to our third patient partner for our steering committee, which is great because we have sort of a succession plan all the time. So this year I'm trying really hard to get our physicians engaged with a patient partner right off the bat. So we're actually doing our orientations today with some of our new docs coming in September. And we're already very, very heavily promoting the idea of involving a patient partner in a way that is meaningful. And I really try and stress that because we've seen token patient partner involvement. And I think probably a lot of people have because they don't understand what value it should bring to both the patient partner and the project lead or the clinician, whatever the case. So I think that's my goal for the next year and on is to make sure it's meaningful. So if it means that patient partner isn't involved in the project team the entire year, it's better that it's meaningful and maybe a one-time thing. So kind of trying to feel that out a little bit. So I'm trying to do a lot of research, see what resources are available in BC and in other places. There's tons of great other countries, even like New Zealand and things like that, where they have great patient partner programs and stuff. So I'm trying to just learn as much as I can and collaborate with other departments and groups like Patient Voices Network and stuff. So yeah, it's been interesting. It's been a huge learning experience.
Yeah, thank you so much for what you do there, Jennifer. I think it's so critical to making sure that when we're trying to redesign a system that we're going in the right direction. Sabrina, you said that bringing patient voices in was a big part of your passion as well.
Yeah.
Tell us about that.
So that's where I started originally was talking with patients and particularly trying to understand people's voices who are not necessarily heard in the system. So when I was in the States, because I did my PhD down at University of California, San Francisco, I was starting to work with Korean speaking and Chinese speaking Spanish-speaking patients, and really trying to hear their voices in terms of different research. So we were interested at that time in terms of decision making and how they perceive risk, and whether or not they can understand different ways in which you might display risk. So risk of getting cervical cancer, risk of getting breast cancer, and trying to understand their understanding of, do you realize that having your purse stolen is more likely to happen than getting cervical cancer, for example. And it's not an easy thing to work with. And so then when I came up here to Canada, continued to talk with people who also were either spoke Punjabi or Chinese. So I think it's really, really important to hear voices that we don't always hear. And the reason why is because if we don't, we're at risk of just recreating the same healthcare system, because we all know who speaks out and who it's like middle-aged women really that speak English, that are people who were flocking quite a lot to, like, for instance, something like Patient Voices Network. And there's nothing wrong with that at all. And I really sort of tried to push people in saying, listen, we have to have a diversity of voices, and we have to try to figure this out. Like, we can't just say, well, it's good enough. And by the way, the languages officially of Canada are French and English. Like, that just kind of doesn't work in British Columbia in my mind. And then I, in particular, because it was primary care, want to make sure that we're listening to men's voices, because they don't often come to primary care as much as women. And again, First Nations, because the issues are different. And we need a diversity of people to be speaking. So yeah, I think it's really important. And we try to have a variety of voices from across the province, actually, in the this thing called the Strategy for Patient-Oriented Research, Primary and Integrated Healthcare Innovation Network. So Jennifer, happy to talk with you more about that if you're interested, because we have a patient advisory group as well in terms of the patient primary care network in British Columbia. That draws on a different set of patients than Patient Voices.
That would be great. Thank you.
Yeah, I think we're coming close to the end of our time. I do you have any questions, burning questions, Jennifer, that you're like, hey, I was wondering about this or that?
I had a question maybe for both of you. When we were looking at that model for high performance primary care, what do you think your template of the future is?
Do you want to go first, Sabrina?
Yeah, so I do think the template of the future is integration. So integration at different levels, right? So integration sort of at a team level that you're working with. So everybody's working at their full scope. Patients can access the care that they need at the right time, at the right place, and with the right person. I also think that there needs to be integration across different services, both in the community, but also with the hospital services. And we know that discharge back to community can be a problem for people. And home care is obviously really important, as is long-term care. So I do think it's all about sort of the integration pieces, and there's like the technology integration that needs to happen, but there's also patient integration, and then the team integration and service integration. So yeah, that would be awesome if we had all that.
Before I tell you mine, I want to know more about team-based care. I feel like it means a lot to you, Sabrina, and for some of us, it just means kind of have your MOAs and your doctors actually communicating. But what does team-based care mean to you?
So I think that there's different people with different skill sets that means that the family physician is working at what they do best. And then you have other people that are able to add to that skill set. So whether that's chronic disease management of populations of patients or groups of patients, whether it's a pharmacist doing sort of medication reconciliation, whether it's counselors who are able to help with the mental health kind of issues that we know that goes on, whether it's social work in terms of, I can't fill out these forms, I, have problems with getting my payments, or elders, as an example of people that need to kind of be there to provide a safe space for people to then be able to have primary care. So I think, to me, that's what I think about in terms of a team-based care, that I have, as a provider, have experts and expertise that I can then draw on in order to ensure that I'm providing the best care that I can to patients, because I know that I myself can't deliver it all.
Absolutely. Jennifer has heard me speak before about my challenges burning out in primary care. And a lot of it was that I was trying to be the whole team in one person, and it doesn't work. I really like how you added in there that elders, and I think what you meant was kind of like elders from that Indigenous viewpoint of having the wise elder and maybe a spiritual leader potentially within each team, someone that you can go to for counsel, someone who can go to for just being there and being in a safe space to heal, to allow your healing and to draw strength from. That's not always quantifiable. I think that's so critical for any team. I think on that model for high-performing primary care, I mean, it's probably because it's a given, but I think physicians focusing on their own wellness is critical to allowing any of it to happen. I remember block number 1 is engaged leadership, and I guess we're looking for physician leadership. We're looking for family doctors to stand up and say, I feel confident as a leader to lead a team that's multidisciplinary, that has an elder and has, all those different other aspects. And I don't think that we're there yet. So if I was to start somewhere, I would probably start at the physician leadership point and have them kind of grow that perspective that you can't do it on your own. You shouldn't expect to, and you've got to ask for help and to learn about some of these frameworks and models that might guide you. And yeah, I think that's one of the missing elements there. Well, any final things? I hope we can do this again. I have a list of other things I wanted to hit, but we never got to them. So if you're open to it, we'll connect again another time. Anything you want to, any parting words you'd like to leave for the listeners? No? How about yourself, Jennifer? No?
Just thanks for the opportunity to chat. I've had so much fun on my Friday night.
Yeah, thank you. Thanks for inviting me. I think what you're doing is great. And you're well on your way to being a physician leader. So that's great. And it's awesome to have talked to both of you. And I hope your listeners would get some benefit out of this.
All 5 of them. I'm just moving clinic this weekend. And I'm really looking to take this opportunity of moving to really reshape and reform how my team is going. All the skills that Jennifer's team has given me in terms of change leadership and quality improvement. And I'm going to try to really make a team that is different. And I might look to you, Sabrina, for resources, for help, for people, mavens in various parts, so that I can build that team that is exemplary. I really want to use data-informed improvement going forward. So thank you for being part of my resource network. And yeah, I'm excited for that. This video podcast will be edited, probably go out in about a week or so. And if people wanted to follow you or connect with you guys or ask you questions, do you guys have public-facing social media things? First, you, Sabrina? And if not, that's okay.
Yeah, I do. I have a Twitter handle, which of course I can't remember what it is, but I'll send it to you.
Okay, you send it to me and I'll have my editor paste it on the thing.
Yeah.
How about yourself, Jennifer?
I have my photography Instagram.
Oh, let's draw some traffic there.
Yeah, we should. Otherwise, no, I have Twitter, but I don't tweet from it. I just creep other people and read their tweets, especially in policy and politics and stuff like that. So, but it is public. If you would like that, I can send that to you after.
Okay, sounds good. Well, thank you and good night. Enjoy the rest of your Friday, and we'll talk again soon.
Great.
Good night.
Later.
Thanks, guys.
Bye, guys.
Bye.
Bye.